So David Bashinsky is a professor of medicine at the University of Rochester and the chief of the nephrology division. And David's going to speak with us now about calcium balance in patients with CKD. And I got you 5 extra minutes.
Thank you, Mike, Dr. Emmett. It's truly a pleasure to be here today and get to discuss an important topic. We're going to talk about calcium balance in patients with chronic kidney disease. Okay. As you know, our patients with CKD have increased vascular calcification. By the time patients become incident dialysis patients, the proportion with vascular calcification increases. And in our prevalent dialysis patients, over 80% of them have calcification, and I suspect if we really look closely, even more than 83% would have calcification. And that calcification has a devastating effect on our patients. In this study by Blatcher, if 0 out of 4 major arteries are calcified, the patients do spectacularly well over 80 months. But with 1, 2, 3, and finally 4 arteries calcified, their survival is worse than most malignancies. Some 20-25% survival after these months if the patients have 4 out of 4 major vessels calcified. Thus, in our patients with chronic kidney disease, there's excessive calcification of soft tissue. Calcium is in the soft tissue where it should not be. If we look at the bone mineral, we see in the wrist and hip, and this is data by Susan Ott, meta-analysis. Each of these symbols is a study. The larger symbols are larger studies. You see at the wrist and at the hip, there's a marked decrease in bone mineral density. The spine is spared, but certainly the wrist and hip have a marked decrease in bone mineral density in our patients with stage 5 CKD. And we all know that fracture, and this is hip fracture data, in both men and women increases with time on dialysis, and in men it's almost tenfold increased risk of hip fracture compared to sex age matched controls not on dialysis. In women it's about 8-fold. And we know that a dialysis patient who fractures their hip has about a 5-year survival of 0. I'm sure there's a patient alive who fractured their hip 5 years ago, but a dialysis patient who fractures their hip has a predicted 5-year survival of 0. Thus, there is decreased bone mineral density in our patients with CKD and increased soft tissue density. In CKD, then, calcium is maldistributed. Less is in the bone where it should be, more is in the vessels where it should not be. And if we think about calcium metabolism in CKD, trying to understand why, we have to recognize that as kidneys fail, they excrete virtually no calcium. Even CKD patients with 4 or 5 are excreting trivial amounts of calcium. Certainly our dialysis patients aren't excreting any calcium. So we have to look at the axis between the intestine, the ECF, and the bone. And we know that net calcium flux into the ECF will promote calcium retention, may promote vascular, certainly will promote soft tissue calcification. Calcium efflux from the ECF lowers calcium, will worsen secondary hyperparathyroidism, may decrease bone mass. So let's think about the ECF, because that's what's important. If you have calcium flowing into the ECF, it can't stay there, it has to go someplace. And where it goes can only be the soft tissues or the vessels. So our goal, I think, is no net calcium flux in relation to the ECF. However, what is the typical physiologic environment of our dialysis patients? They have some acidemia, some secondary hyperparathyroidism, and we tend to give them vitamin D or the analogs of vitamin D. Let's think about each of these in turn. Jack Lemmon taught us that acidosis, metabolic acidosis, doesn't affect intestinal calcium absorption. We've studied bone extensively and shown that metabolic acidosis increases bone formation, increases bone resorption, decreases bone formation. So if you have more calcium coming out of bone, less calcium going into bone, ECF calcium increases. Our patients have elevated PTH. As you know, PTH doesn't affect intestinal calcium absorption. It clearly increases bone resorption. It increases bone formation as well, but as we know, the increase in resorption is greater than the increase in formation, so again, calcium is added to the ECF. How about 125D or the analogs? We give our patients lots of 125D. The principal effect of 125D is the increase in intestinal calcium absorption. It also, in high doses, increases bone resorption, has little effect on bone formation. So if you have increased absorption, increased resorption, you're going to again get increased ECF calcium. So the typical physiologic environment of our dialysis patients, the acidemia, the secondary hyperparathyroidism, the 125D we give them, all promote calcium movement into the ECF, and that calcium has to go someplace. It can't just sit there, otherwise serum calcium levels would rise. But the physicochemical forces cause that calcium to be deposited. But it's a little more complex with our dialysis patients because we have to consider the dialysis machine. Between treatments, of course, the calcium influx into our patients depends on their diet calcium, if there's calcium in the binder, and the use of 125D. As we all know, the more calcium you take in, the more you absorb. In this segment, it's about D-mediated, but here vitamin D is suppressed, but you still keep absorbing more calcium as you eat more calcium. 125D has an incredible influence on calcium absorption, increasing absorption tremendously. But we have to then think about during the dialysis treatment. During the dialysis treatment, diffusion is simply dependent on calcium gradient. This is dialysis 101. The higher the dialysate calcium, the more calcium influx into the patient, the lower, the more efflux from the patient. But we also have to think about convective transport. Every time I remove a liter of UF, of ultrafiltration, I'm taking calcium with it. So we have to take that into account. So what's the ideal calcium concentration in the dialysate? The best guess that we have, the best estimate that we have is about 1.25 millimolar or 2.5. At a higher dialysate calcium concentration, calcium moves from the dialysate into the patient, raising serum calcium. At a lower dialysate calcium concentration, it moves from the patient into the dialysate, lowering the serum, the plasma calcium concentration. 1.25 millimolar, 2.5 milliequivalent seems about right. In this balance study by Susan Ho, low calcium dialysate led to a negative calcium balance, a higher calcium dialysate calcium concentration, higher calcium balance at 1.25, pretty close to neutral. There have been 4 studies just like Susan's. 1 showed positive balance, 2 showed negative balance, 1 showed really neutral balance. So for the purposes of putting this all together, we're going to assume a neutral balance. So now we can model what happens to calcium in dialysis patients. But we have to make some assumptions because we don't know everything, and we also have to assume things like dialysis 3 times a week. We have to assume that the bath is 1.25, and I tried to show you that that's about the best physiologic bath that we have, 2.5 milliequivalent. There's no net calcium flux during dialysis if there is no ultrafiltration, a reasonable assumption based on the 4 studies that I showed you. My patients need about 3 liters of UF. I'm sure your patients are better, but we're going to assume that our patients need about 3 liters of ultrafiltration during each dialysis treatment. Importantly, we're going to have to use the data from Jack Coburn from years ago that shows what the calcium absorption is with and without D. And based on Jack's beautiful work, we're going to assume 19% absorption without D, 25% with D. We're also going to say that all calcium will be absorbed equally. There's infinite combinations of calcium with every anion you can think of. And that will influence absorption, so we're going to have to say all calcium is absorbed equally. Calcium secretion into the stool, we're not going to talk about over lunch so much. Calcium is lost in the sweat. Urine calcium we will assume is 0. In CKD, it's small, not quite 0, but certainly in dialysis it's 0. And we're going to say that there's no net calcium flux relative to bone. Now, this means that every number I give you of calcium retention in the ECF is an underestimate, because secondary hyperparathyroidism, administration of 125D, and metabolic acidosis all will cause calcium to move from the bone into the ECF. So, now we can put this together. We can estimate calcium intake with and without D. So at about 1.5 grams of calcium a day, 1,500 milligrams, no D, patients are in very small positive calcium balance. Over a year, it's a small amount of calcium. As soon as we add vitamin D to that mix, to the 1,500 milligram calcium intake, the model tells us that our patients are retaining more calcium in their ECF, and over the course of the year, it's not an insignificant amount of calcium. You start getting up to 2 grams of calcium intake, no D, we're again adding about 1,000 millimoles, or a mole of calcium. 2 grams of calcium with D, 2 moles of calcium, 2,000 millimoles a year, about 6% of total body calcium, is being added to the ECF, and for the third time, it can't stay there. It has to diffuse out someplace. Where is it going? So we can, using that data, put together this graph, which I published initially in CJSON, with all the equations, and then, in spite of my colleagues who are nephrologists liking math and equations, they asked me to do it without the equations, and that's an NDT this year. And what does it show? Without vitamin D, about 1.5 grams of calcium intake will not result in appreciable net calcium movement into the ECF. If you add more calcium, you're going to get movement into the ECF. However, once you add 125D, or the analogs, to the mix, 1.5 grams of calcium will lead to positive calcium balance, 1 gram of calcium relatively neutral. So 1 gram with D, 1.5 grams without D. Calcium metabolism, then, we were talking about. Calcium movement into the ECF will result in movement of calcium into the soft tissues. So this is a theoretical argument. Everything I've told you is based on the available data that we have. But what's nice is, since this analysis came out, there have been 2 clinical studies. One is by Dr. Spiegel, who's sitting right there. And what David did with Brady is did a balanced study on a low or a higher calcium diet in 6 control patients and 6 patients with CKD. 9 days, and then they did the balance on the last 2 days. They waited a few weeks, switched them over, they did them randomly. What did David find? And this is published in Kidney International. Normal patients, 800 milligram calcium diet, about neutral calcium balance. Once you get up to 2 grams of calcium, positive calcium balance, but small. Look at our patients with CKD, CKD 3 and 4. 800 milligrams, neutral balance, just like the model predicted. Once you get to 2 grams, markedly positive calcium balance in every single patient. These patients are retaining calcium. That calcium's can't continue to go into bone because pretty soon bone is saturated. Where is it going to go? There's another study, Hill and Sharon Moe and Monroe Peacock. It's accepted in KI. It's not out yet, but it has been accepted. They studied 8 patients, CKD 3 or 4, did 2 3-week balance studies, 1,500 milligrams of calcium versus placebo. The diet had about 1 gram of calcium. Phosphorus absorption fell with calcium carbonate. Urine calcium also fell, so calcium was a good binder, but no difference in phosphate balance. However, there was clearly positive calcium balance in their patients with given calcium carbonate. About 500 milligrams per 24 hours with calcium carbonate, positive balance, which is essentially 0 with placebo, a highly significant difference. So 2 out of 2 patients with CKD have validated the model that patients getting a lot of calcium are retaining that calcium. So let us conclude. Many of our dialysis patients on a 1.2 millimolar calcium bath have an increase in ECF calcium even if they consume 1.5 grams or 1,500 milligrams of calcium while receiving active vitamin D. The amount of calcium is significant. This is not a trivial amount of calcium. If your patient's on 2 grams of calcium and getting 125D, they can retain about 6.5% of total body calcium over a year. Clearly, further studies are warranted. We need to do these studies in dialysis patients to determine if the assumptions that I told you about are valid and what is the fate of this retained calcium. We don't know. But 2 clinical studies in patients with CKD clearly support the fact that if you give your patients lots of calcium, especially with vitamin D, they're going to retain that calcium. And with that, I thank you for your attention, and I finished 2 minutes early for Dr. Spiegel.